This video will be explaining the action potential of non-pacemaker cardiac cells. These are the contractile tissue of the atria and the ventricles. We start by looking at the cell at rest. This is phase 4 of the action potential. In this phase, the cardiac cell membranes are most permeable to potassium, as the only channels currently open are the potassium rectifying channels, which allow passive movement across the membrane. This means the membrane potential is mainly determined by the equilibrium electrical potential for potassium, which is around -90 millivolts. A cell must then receive an electrical stimulus from an adjacent cell, which is sufficient to increase its membrane potential above the action potential threshold of -70 millivolts. If the action potential threshold isn't met, the cell membrane returns to rest and no action potential is elicited. This describes the all-or-nothing principle of action potentials. Upon reaching the action potential threshold, fast sodium channels are opened. These channels permit a rapid influx of sodium into the cell, which drives the membrane potential towards the equilibrium for sodium, which is around +50 millivolts. Potassium rectifying channels are also shut as the membrane potential is met, producing the rapid depolarization that we see in phase 0. As the membrane is being depolarized, we also see L-type calcium channels begin to open at around -40 millivolts, which allows a slow influx of calcium ions into the cell. Calcium's effect on the membrane potential at this point is minimal, but it does fulfill an important role later on. At a voltage of +50 millivolts, sodium channels are inactivated, and transient-type potassium channels open and close very quickly, allowing a brief period of hyperpolarization that creates a negative slope and the notch of phase 1. Once the transient potassium channels close, slow outward flow in potassium channels open, allowing a slow exit of potassium ions from the cell. L-type calcium channels, which have remained open since phase 0, continue to allow calcium ions into the cell slowly. These calcium ions bind to receptors on the surface of the sarcoplasmic reticulum, an organelle which acts as an internal store for calcium. The binding of extracellular calcium triggers the release of stored calcium ions from the sarcoplasmic reticulum into the general intracellular environment. The presence of calcium also triggers the opening of inward flowing chloride channels, letting chloride ions into the cell. The net movement of calcium, potassium, and chloride ions contributes to the maintenance of a fairly constant membrane potential, which creates the plateau phase of phase 2. Intracellular calcium has a number of important targets, one of which is troponin C. This is the protein responsible for the contraction of non-pacemaker cells. Another important target is a protein called calmodulin, which is responsible for the inactivating open calcium channels. It is normally present within the intracellular matrix, but is only activated after it has bound free calcium ions to form a calcium-calmodulin complex, essentially mediating a negative feedback system by which calcium terminates its own release into the intracellular matrix once there are enough calmodulin complexes to inactivate all the open calcium channels. The inactivation of calcium channels brings an end to phase 2, and triggers the opening of fast outward flowing potassium channels and begins the descent of the membrane potential back towards the equilibrium for potassium. This is represented by the downward slope of phase 3. Towards the end of phase 3, potassium rectifying channels begin to reopen, which allow the passive movement of potassium across the membrane and contributes towards the final part of repolarization during this phase. Once the membrane potential reaches the equilibrium for potassium, fast channels close, leaving only the rectifying channels open to maintain the baseline membrane potential, taking us back to the rest phase. It should be noted that intracellular sodium and potassium concentrations are corrected to their pre-excitation levels during this phase. This is done by a series of sodium and potassium co-exchanges which prepare the cell to elicit its next action potential. This then brings us to the end of a full action potential cycle. With an understanding of how the electrolytes interplay during the cycle, it becomes possible to understand how the arrangement of these electrolytes or drugs that target specific relevant channels induce their cardiac effects. Looking back firstly at calcium, we first see it enter the cell through L-type channels at -40 millivolts. We then see a further release of calcium into the intracellular matrix from the sarcoplasmic reticulum in the presence of extracellular calcium. The flow of calcium is then stopped once calcium channels are inactivated by calmodulin complexes. When serum concentrations of calcium are higher than normal, there is a quicker influx of ions into the cell through the L-type channels due to the increased competition for the same number of channels. This means calcium receptors on the sarcoplasmic reticulum are bound quicker and therefore release their stored calcium into the intracellular matrix quicker. Calmodulin complexes are formed at a faster rate, causing an earlier inactivation of calcium channels and thus an earlier termination of phase 2. This overall leads to a faster conduction velocity as the next action potential can begin sooner, causing a tachycardia. The plateau is also slightly flattened as the positive calcium current is increased relative to the negative potassium current. Inversely, low serum calcium concentrations result in a slowing down of the processes that eventually lead to the inactivation of calcium channels. This causes a prolongation of phase 2 and slows down the overall conduction velocity as the next action potential cannot begin before the cycle is concluded. The plateau also bears a more negative slope as there's a reduced calcium current relative to the potassium current. Cardiac-specific calcium channel blockers, aka your class 4 antiarrhythmics, work by essentially creating a relative hypocalcemia. Through their actions primarily on the sarcoplasmic reticulum, they reduce the number of channels available for extracellular calcium to bind to, slowing down the cascade that eventually leads to the inactivation of calcium channels, thereby prolonging phase 2 and slowing down the overall conduction velocity. This explains the rate-limiting properties of drugs such as verapamil and diltiazem. Next, we move on to potassium, which is responsible for the repolarization of the cardiac membranes, as well as maintaining the resting membrane potential through its action at the rectifying channels. It's important to note that due to the passive correction of potassium that takes place through rectifiers and potassium exchanges, there is a strong correlation between the intracellular and extracellular concentrations of potassium. Therefore, in a state of hyperkalemia, intracellular potassium concentrations will also be high, and in hypokalemia, they will be low. When potassium concentrations are high, potassium ions will be able to traverse the membrane quicker at all channels due to an increased number of ions competing for the same number of channels. The most prominent effect of this is seen during phase 3, as this is when most of the potassium exits the cell. The faster potassium exit brings the membrane potential back to the equilibrium for potassium at a quicker rate and produces a more vertical slope in phase 3. The conduction velocity is overall faster and we get a tachycardia. With an increased outward potassium current relative to the inward calcium current, the plateau also becomes more negative. Inversely, when potassium concentration is low, potassium traverses the membrane slower at all channels as less ions are competing for the same number of channels. Again, the effects are most prominent in phase 3, with slower potassium exit causing a delayed repolarization and a less vertical slope. This overall slows down the conduction velocity and produces a bradycardia. There is also a more positive inward flow of calcium relative to the reduced outward potassium current, creating a flatter plateau. Potassium channel blockers, aka your class 3 antiarrhythmics such as amiodarone and sotalol, work primarily on the fast outward flowing potassium channels, reducing their effective numbers and slowing down the potassium efflux, thereby prolonging phase 3 and slowing down the overall conduction velocity. They are used to good effect in correcting tachyarrhythmias. Lastly, we take a look at sodium, which makes its only contribution in phase 0, where it rapidly depolarizes the membrane as it enters the cell. As sodium is vastly more abundant in serum than other electrolytes, it will typically require an absurd degree of derangement to affect the speed of depolarization. However, in theory, sufficiently low serum concentrations would slow down the rate at which sodium ions cross the cardiac membrane, tilting the depolarization slope slightly to the right. And sufficiently high sodium concentrations would increase the rate of entry of sodium into the cell and tilt the depolarization slope slightly to the left. The rest of the action potential would simply be a continuation of the normal process from the depolarization endpoint in both cases, creating a slower conduction in hyponatremia and a faster one in hypernatremia. But again, it would take a lot to go wrong here if any changes are to be seen. A far more effective means of slowing down phase 0 would be to reduce the availability of active channels by which sodium may flow into the cell. This is precisely what sodium channel blockers do, aka your class 1 antiarrhythmics, such as flecainide. Finally, I'm going to be talking about the refractory period, which is a period of time during an action potential cycle in which a cell cannot elicit another action potential even if it receives a sufficient electrical stimulus. It starts at the beginning of phase 0 and continues to the end of phase 3 and effectively represents the QT interval on ECGs. It is a protective mechanism that prevents the compounding of multiple action potentials. It can be split into an absolute and a relative period, the absolute period being from the beginning of phase 0 to halfway through phase 3, during which absolutely no action potentials cannot be initiated, and the relative period being the rest of phase 3. And during this period, it is possible for an action potential to be initiated. However, stronger than sufficient stimulus would be required to do so. This is why inappropriate defibrillation and electric shocks in general are considered to be so dangerous. The relative period exists because as the cell begins to repolarize, previously inactivated sodium channels are reactivated at around minus 50 millivolts and are technically available for reuse from that point onwards, although they generally remain closed. However, if they receive a trigger that causes them to reopen, they would be able to facilitate the influx of sodium ions that would begin a new action potential. The protectiveness of the refractory period is diminished when it is inappropriately extended beyond its normal limit, although strictly speaking, problems are only caused by the lengthening of the relative refractory period. A new action potential superimposed on top of one that was not fully completed could lead to the generation of dangerous and unstable tachyarrhythmias such as torsades, which carries the risk of degenerating into ventricular fibrillation, causing a cardiac arrest. As this period exists during a phase defined by the outflow of potassium ions from the cell, any disorder that reduces the availability of potassium or slows down its transit across the cardiac membrane, such as hypomagnesemia, hypokalemia, long QT syndrome, predisposes to torsades. In fact, long QT syndrome in itself simply describes a family of channelopathies that affect the expression of calcium, sodium, and potassium channels, all of which are ions that we know to have an effect on the span of the refractory period, or the QT interval. However, the most common and most significant mutation are those that affect potassium channel expression. Because of this risk, concurrent use of class 3 antiarrhythmics, which we know to extend phase 3, alongside other drugs known to prolong the QT interval, such as macrolide antibiotics, antifungals, SSRIs, or in conditions where it may be pathological prolonged already, is not advised.